with sepsis. Now, this is kind of a heavy topic to start with, but I like to start with sepsis because a lot of the things that we talk about in sepsis as far as what patients look like and what we do for patients based on their symptoms and what they look like can apply to a lot of different disease processes. So I think it's a good place to get your brain started to start thinking about some of these concepts. Sepsis in particular is a really big responsibility of us as nurses, okay? We're the ones that are at the bedside. We're the ones that are there with the patients the majority of the time. We're the ones that recognize sepsis. We're the ones that are the eyes and ears of the providers that pick up on this, report it to them so that something can be done. The reason nurses are so important also is with sepsis in particularly, the earlier that you catch it and the earlier that you treat it, the better outcome for your patient, okay? Has a really high mortality rate, and the later that we pick up on it, the higher that mortality rate goes. So it's really important for us as nurses to be able to identify this. Now, the first thing that I'm going to do here is I'm going to show you this video on, it's about some real life stories of patients that developed sepsis and what happened to them, okay? And this will kind of give you an idea of why this is so important. This will also give us a brief overview of sepsis, and then we're going to talk about each part a little bit more in depth.
Our daughter Erin was 23. She had just graduated from the University of Georgia. She was going on to graduate school, University of South Florida. She went in for a simple hemorrhoidectomy on a Thursday. 5 days later, she was gone. To something I had never heard of.
Many death certificates list the cause of death as cancer. Many of those patients die of sepsis. Many death certificates list the cause of death as complications of heart disease, and the cause of death is sepsis. Many death certificates list the cause of death as complications of pneumonia, and the cause of death is sepsis.
According to a recent poll, close to half of all Americans have never heard the word sepsis.
And in fact, I practiced dentistry for 25 years, and I didn't know anything about the sepsis.
We have more than 1.6 million cases of sepsis annually in this country. And of those cases, nearly 20% wind up dying.
There is an epidemic that is occurring in sepsis. This has been increasing in the number of cases by about 9% per year. Certain groups of people seem to be at higher risk for sepsis. That includes people like the very young, elderly people, people with chronic conditions like cancer or liver disease. People who are over the age of 65 are 11 times more likely to have a hospitalization associated with sepsis than someone who's less than 65. But there should be no mistake. Sepsis is an equal opportunity killer. It kills the young, it kills the old, it kills the sick, it kills the healthy. Sepsis is really a toxic response to an infection. So your body is constantly inundated with challenges by microorganisms, bacteria, viruses, fungi. And you have an extensive system in your body to try and keep that bacteria from becoming an infection. The problem is that body can also go haywire. And so as a result, instead of protecting you, your body actually starts trying to kill you.
The immune system is mobilized to action like an army, and the white blood cells are firing bullets at the bacteria or at the invaders. And that's fine when the bullets are targeting the bacteria, but it becomes a real problem when the bullets start flying everywhere and you get collateral damage on the patient's own organs, and this becomes a catastrophe.
So you may hear a number of terms that are used in the hospital around sepsis. There's sepsis, severe sepsis, septic shock. Sepsis is at its basic heart this notion of having systemic inflammation due to an infection.
In some instances, sepsis progresses to the point that people's organs fail. When your organs fail or aren't working correctly, this is called severe sepsis. The most serious form of sepsis is when your blood pressure drops as a result. This we call septic shock.
Erin went in on a Thursday for elective surgery, hemorrhoidectomy, just a routine surgery. I had had it done before, and on Friday, they dismissed her for the weekend. Well, everything seemed okay until Sunday night, and all of a sudden it had turned for the worse and the pain level went up. Well, that's completely contrary to a healing phase. So my wife took her back to the hospital, but I kept her Sunday night. I went in Monday to see what's going on, and I could tell something was wrong. I mean, I could see her blood pressure was off, very low, her heart rate was up. I said, "Where's the doctor?" He said, "Well, he's down there." I said, "Well, go get him." And he walked in, he said, "I think she's septic." It's the first time I heard the word septic. She had the infection when she came home on Friday night, but they did not give antibiotics because they told her they were concerned it would cause diarrhea. So if she would have had the code sepsis that we referred to, that is fluids and antibiotics on a Friday night, this was all preventable. And it's such a shock for that to occur and someone die from something you've never heard of. And that changed my life. I was with her when she died. She looked at me and said, with her eyes, "Can't you do something, Dad?"
If doctors treated sepsis as a medical emergency in all instances, as many as 50% of deaths occurring now wouldn't happen. And so that's 125,000 people surviving every year who would have otherwise died.
We think that one of the ways to emphasize the need for treating sepsis like a medical emergency is to refer to this in the same way that we refer to other medical emergencies, which is as a code. If you're in a hospital, you might hear a code blue. That means that there's a team that responds to someone whose heart is stopped. We're trying to promote the notion of a code sepsis. And what code sepsis is, take this disease seriously. Suspect it, administer early antibiotics, administer fluids, and get the help you need to provide the care for the patient.
Reducing mortality in sepsis is as easy as getting antibiotics into patients. What we also know is that your mortality goes up by about 8% for every hour that passes without antibiotics. Unfortunately, there's not a single sign or symptom that really tells you have sepsis.
But I think there are some warning signs that people can look out for. These can include things like problems breathing, a fast heart rate, either a high temperature or chills, feeling dizzy or lightheaded, particularly when you stand up, and problems with changes in the level of consciousness. And this can include either confusion or possibly being difficult to arouse.
If you're concerned about sepsis, one of the things to do is, when you talk to your doctor, say, "I'm worried about sepsis." That cues the doctor to think about this as a problem and do further testing.
The first time I felt the sore throat coming on, it was a Friday night. It was just like a slight soreness in my throat, nothing major. The next morning I woke up and it was the worst sore throat of my life. I actually could barely talk. I was having trouble breathing. I started running a really high temperature. I started throwing up blood. That's when I realized it was time to go to the emergency department.
And at that time, the thought was that she probably just had a viral illness like a cold leading to a sore throat. Over the next couple days, however, she got worse. Had increasing confusion, noticed her skin was mottled or had a blue discoloration, and wound up coming to the hospital a second time.
When I was admitted to the ER, they reported that I was already in septic shock. I had H1N1. I was in renal failure.
In Jen's case, her sepsis led to the formation of small blood clots in small blood vessels throughout her body. As a result of that, she didn't get enough blood flow to her extremities, and that led to gangrene, which is tissue dying.
And I do remember looking at my hands and seeing that they were black and they were curled into like a claw because they had died, but not understanding what that meant. And also seeing my feet and toes and they were black.
As a result of that, she required amputations.
I remember my mom coming into my room and saying, "It's time for you to go to your surgery." And I just started crying because I felt like I wasn't going to make it through the surgery. And there's so much I wanted to tell my mom, but I couldn't talk at the time. So I just said, "I'm sorry."
It's hard to really understand how sick she was. Her family was called in multiple times to her bedside because the doctors all thought she was going to die within minutes. and she was as close to death as anyone can be.
It was extremely touch and go for months.
She just slowly started getting better, but it still took her months to recover.
So notice here she's got partially amputated hands and she's got amputations on both
The
legs.
great unknown is the number of
And
people
that
who survive
started with a
sepsis,
sore throat.
but
She
are
went to the
significantly
ER and was
disabled
sent
as a
home
result.
because they didn't
Those
recognize that
disabilities
she
can
was
be
becoming
obvious,
septic.
things like amputations, but they also can be things that are hidden, like problems with thinking, memory, calculations. Some even suffer from post-traumatic stress disorder. We feel happy that they've survived, but they're still carrying the scars around with them for the rest of their lives.
Well, I want to share my story because I've always wanted to help people, and I think this is a good way. I've always had that drive, but now it's in me even more. It makes me feel good if just one person knows what sepsis can do and how important it is to get treatment for it immediately so that there aren't grave consequences.
And it all comes down to hope. That is, hope from shared responsibility that an informed public can work with their healthcare providers to reduce the deaths and disability from sepsis. The public will have to be empowered to demand and ask for
I'm just gonna
early
skip
treatment.
the rest of that. Okay. Okay, so why is sepsis so important? I think that the video touched on why it is so important. The mortality rate is very high. Complications from sepsis can be very scary and very detrimental to the patient. It is a leading cause of death in U.S. hospitals. Okay, so this is a really big deal, and this is why nurses are at the forefront of this. It kills as many people as heart attacks. Most people don't know that. You know, we're very focused on heart attack education, MI education. We've educated the public ad nauseum about chest pain, right? The public knows now if they have chest pain, they're supposed to take an aspirin and call 911, right? Well, we should be educating patients just as much on this as we do heart attacks. We're getting better with sepsis, but we're not quite there yet, okay? One of the things, like he said in the video, some hospitals are going to is what's called a code sepsis, where you initiate interventions very quickly if you recognize these signs and symptoms. Now, not all hospitals have gone to that code sepsis format yet. However, you as bedside nurses all have access to rapid response teams, right? So if you were in a hospital setting working and you really feel like that your patient is exhibiting signs and symptoms of sepsis, of course you're gonna call the provider and let them know, but another resource that you have is to get your rapid response team involved so that you can get this patient the right interventions very quickly. Also has the highest readmission rates. So this is why patient education at discharge is extremely important, and we're gonna talk a lot about discharge teaching in this course, and especially in regards to sepsis. The rate of sepsis is going up every year. Why do you guys think that is? Why do you think more people and more people are becoming septic?
Antibiotic resistance?
That's one of them, right? Our antibiotics aren't working as well. We've got all these super bugs. Bugs have gotten really smart, and they're not as susceptible to the antibiotics that we give patients. Why else do you think the sepsis rate is going up? What's happening to the age of our population? It's going up, right? People are living longer. And because of that, we have more people in the population that are susceptible to sepsis, right? He said one of the risk factors for sepsis is being very old. So we have a lot more people that are very old, okay? So the risk of sepsis is going up. There's another one, another reason that incidence of sepsis is going up. It's a little bit harder one to think about, but it has to do with how we treat patients in the hospital setting as far as healthcare dollars are concerned. What's something that we're doing now that maybe we didn't do in the past that's increasing risk of sepsis, you think? Earlier discharge, that's exactly right. So we are sending patients home, how we say, quicker and sicker than we ever have, right? People are in and out as quick as we can get in and out, right? Because we need the bed for the next patient coming along, because reimbursement rates from insurance companies have gone down. So we're sending these people home faster than we ever have, okay? Which is another reason that discharge teaching is so critical and so important to keep your patient from coming back to the hospital with sepsis, okay? This diagram is in your book. This is talking about the different stages of sepsis. We're going to talk about each of these individually, but I'll point some things out here. So it starts with a local infection, of course, okay? If that local infection is not contained or not treated, and the infection gets into the bloodstream and then goes what we call systemic, it becomes sepsis, okay? After that happens, you'll get this, what we call systemic inflammatory response syndrome, which we'll talk about in a minute. It's also called SIRS. If it's not treated at that point, the infection can lead to organ failure, so failure of the kidneys especially is one that we'll talk about. May also lead to what we call multiple organ system syndrome, or multiple organ system dysfunction, where you have organ failure all over the body, okay? That's also called septic shock. Once your patient gets to septic shock, your chances of rescuing them, or the chances of their survival, are pretty minimal, okay? So we have to stop this sepsis cascade before they get to septic shock, because once they get to septic shock, most of the time our efforts are going to be futile. We're not going to be able to save that patient, okay? And of course, the last step of this sepsis cascade is going to be death. Okay, so let's talk about what happens with just a local infection to remind ourselves of how our bodies respond to a local infection. So let's say that we have a patient that has a cut on their arm, okay? So they get a cut on their arm and the cut becomes infected. So what kind of signs or symptoms would the patient exhibit that would let us know that, hey, that cut's probably infected? What are your normal signs and symptoms of infection? Redness, swelling, what else? Fever possibly in the patient, could be heat at the site, right? What else might tell us the patient has an infection? Probably some drainage, right? Anything else? I think we've hit on the main ones there, okay? So we talked about swelling, we talked about redness, heat, fever. Also don't forget pain. They may have some tenderness or pain at the site, right? So that's what happens in a local infection. So let's talk about now, why does the patient experience those particular symptoms, okay? So when a patient has an infection in a local area such as the arm, what in our blood is going to rush to that area? What particular types of cells rush to an area of infection?
Is that like the eosinophils and immunoglobulins?
But what's the broader term? White blood cells,
Yeah.
right? Our white blood cells is the part of our blood that helps us fight infection, right? So if we have an infection, have a cut on our arm, have an infection, all the white blood cells in the body are going to go to that site, right? Especially the ones in the area of the site are going to go to that site to try to fight that infection, right? When the white blood cells get to the site, one of the things that happens is the white blood cells trigger release of what we call cytokines, pro-inflammatory cytokines, okay? The key word there is inflammatory, okay? So when the white blood cells get there, they trigger that cytokine response. The cytokines create an area of inflammation, okay? Now normally that inflammatory process is very helpful, okay? One of the things that we'll see in the patient though is we're going to see the redness and edema, right? As a result of that inflammatory process. But what's really happening in the vasculature is all of the vessels in that area are going to dilate, right? Why do you think that the vessels or the capillaries in that area of infection are going to dilate? What's the purpose of that?
To get more white blood cells to the area.
To get more white blood cells to the area, right? Because if you vasodilate, you're going to increase perfusion to that area. You're going to get more blood to that area of the infection. And in that blood is going to be more white blood cells, right? It's going to help the body fight that infection. So one thing that you're going to have is this big vasodilation, okay? More white blood cells to the area, more white blood cells, more cytokine trigger, more inflammatory response to help fight that infection, okay? Now, another thing that happens as far as how the patient gets edema in the area is with that vasodilation, the little tiny capillaries in the area of the infection are going to become what we call more permeable, okay? And the capillaries are going to leak a little bit, okay? So the blood in that vasculature is going to leak a little bit in the area and cause some swelling, okay? And normally that's not a problem. And when we have a local infection, that whole process, right, might take a few days. That whole white blood cell inflammatory response, vasodilation, helps fight the infection. In a few days, our body takes care of it, right? Now, think about that whole process happening over the entire body, okay? So now we have, when we go to sepsis, so we talked about local infection, and let's talk about sepsis. Sepsis is an infection that's no longer contained locally. So for whatever reason, the body couldn't handle it on its own. And so the infection gets into the bloodstream and goes everywhere, okay? Now, can be caused by bacteria, can be caused by fungal infections. Gram-negative bacteria is the most common type, okay? That's the most common type of bacteria that leads to sepsis. But think about that inflammatory process I just talked about. So now it's happening everywhere, all over the body. You've got vasodilation, you've got increased capillary permeability, so your capillaries are leaking all over the body, okay? You can see how this can cause some problems, right? So let's talk about, what do you think would happen if you have systemic vasodilation? What happens to our blood pressure? It's going to go down, right? If our vessels all over our body open up wide, our blood pressure is going to go down, right? Once our blood pressure starts to go down, what's going to happen to the oxygenation of our tissues? It's going to be decreased, right? If you have vasodilation, decreased blood pressure, you're going to have decreased oxygenation to those tissues, right? Now, there's a couple of things we'll get to in a second as far as compensation. So I just want you to think about that in your head. This widespread vasodilation, you've got this widespread capillary leak everywhere, okay? Decreased oxygen to the tissues, okay? Let's talk about some things here. So we talked about the blood pressure is going to go down, okay? Now I'm talking here about each step of this sepsis process. Like the other slide said, it said early sepsis, SIRS, then you go to severe sepsis, septic shock, and then death, okay? So we're going to talk about each step here a little bit. Now the important thing to remember, especially in early sepsis, is that your patient may only have very subtle changes in the way that they look. This is why it's really important to pay attention to what's going on with your patient. So they may have some mild hypotension due to the vasodilation all over their body, okay? Why do they have decreased urine output?
Decreased perfusion of the kidneys.
There's really two reasons, okay? They kind of go together, but there's really two reasons. One of the reasons is decreased perfusion to the kidneys, right? If the blood pressure goes down, not as much blood gets to the kidneys, renal perfusion goes down, urine output goes down, okay? There's another reason why urine output goes down. Why is that?
It's trying to hold on to fluid.
It's a compensatory mechanism, right? So our bodies are really smart. So the body says, oh my gosh, the blood pressure's going down. I need to reserve all the fluid that I have, right? So the kidneys will stop with the urine output to keep all that fluid in the body to hopefully preserve that blood pressure, right? So there's really two reasons that urine output goes down. But it could be a very minimal change at first, okay? Now, your patient's respiratory rate may go up in these early stages. Why would their respiratory rate go up?
Putting acid on.
That's part of the reason. It is going to be a metabolic acidosis, but part of the reason that the respiratory rate goes up is because of lack of oxygen to the tissues, right? It's another compensatory mechanism. So you have that widespread vasodilation, blood pressure goes down all over the body, you have decreased perfusion to the tissues all over the body, and the body tries to compensate for that by increasing the respiratory rate, right? The body thinks, if I start breathing faster, I'll get more oxygen in the body, more oxygen to the tissues, okay? So your patient's respiratory rate's gonna go up. Elevated white blood cells kind of goes without saying, right? We're having a big immune response, a big inflammatory response to that infection, so you're gonna have increased white blood cells to a point, and we'll talk about that in a second. Now, another thing that's gonna happen is inappropriate clotting. And they touched on this in the video, and this is what happened to the girl that had to have the amputations as a result of sepsis. So remember I said that when you have this infection, you have vasodilation of your vessels, right? And those capillaries become more permeable, and you'll have a little bit of blood pooling wherever you have that vasodilation, right? So if you have a local infection, you have a little vasodilation there, you have that capillary leak that happens, your body's gonna respond to that by sending clotting factors to the area, okay? And as the infection improves, that capillary leak will improve, okay? Now think about this all over the body. So you have this widespread vasodilation, you have increased permeability of your capillaries, you have blood that's leaking out of the capillaries, right? And the blood pressure's going down, okay? You got all those factors together. Well, the body's gonna respond to that by saying, oh my gosh, the body's bleeding everywhere, right? Even though it's a small amount of blood because it's in the capillaries, the body's still gonna respond to that, especially in conjunction with hypotension, okay? And the body thinks, oh, I gotta do something about this bleeding everywhere, right? I gotta stop this bleeding everywhere. So the body's gonna send out all these tiny little microthrombi, okay? All these tiny little blood clots, are gonna start to form in those capillaries to try to stop the bleeding that's happening in those capillaries, okay? Which presents a problem, okay? Because if you have blood clots in a vessel, what happens to perfusion to that area? Stops perfusion to the area becomes ischemic, the tissues start to die, right? But guess what else happens when your tissues when cells start to die in that manner? More cytokines are released, and that inflammatory process even keeps going even more and more and more and more, okay? And your patient ends up with a hypodynamic state, okay? That goes back to the low blood pressure. Now in severe sepsis, so this is the next stage. We've gone from this early sepsis, systemic inflammatory response, to severe sepsis. Now, don't be fooled by severe sepsis, because your patient may actually look a little bit better for a minute, okay? Their blood pressure may start to improve. Why?
The other factors are working.
It's all those compensatory mechanisms, right? So we said that the kidneys will stop putting out urine to try to increase the blood pressure, right? It's basically trying to fill up the tank, okay? Trying to put as much volume of fluid in the tank to keep the blood pressure up. But something else happens here. You have elevated heart rate, okay? So why does the heart rate go up?
Oxygenation.
It does help oxygenation, but the heart rate going up is another compensatory mechanism, right? Anytime your blood pressure goes down, your heart beats faster, okay? Remember, your heart is the pump of the body, and whenever the pressure goes down in the system, the heart is gonna start pumping harder and faster to try to improve that pressure, okay? So that heart rate going up is trying to compensate for the blood pressure being low. Now, when your patient goes through this sepsis cascade, the heart rate going up actually works really well for a minute. And so this is why your patient looks better. They become pink and warm, their blood pressure goes up a little bit, and their cardiac output becomes improved, okay? So they may look a little bit better for a minute, okay? But remember that our heart and our bodies can only compensate for so long, okay? The key difference here, though, is these mental status changes, okay? And that has to do with lack of oxygen to the brain, okay? As a result of that low blood pressure that the patient was having, they get decreased perfusion to the brain also. They start having some mental status changes or behavior changes as a result, okay? So even though they may look better on paper as far as their blood pressure is a little bit better, heart rate is increased and their cardiac output is improved, that tissue hypoxia is still occurring, okay? Now, once they progress to septic shock or multi-organ failure, they look bad, okay? These patients are very sick. They will have a low blood pressure, low cardiac output. Heart rate will still continue to be high because the body's still trying to compensate, but it's not doing a very good job anymore, okay? Their skin will be cool, clammy. They may have the modeling bluish color of their skin. So these are not good signs. This is a patient that should be in an ICU setting, okay? This diagram is also in your book, and it's what we've already talked about, but I like this slide to put up here if you're kind of a visual person. What this is telling us is that vicious cascade that happens. So once the patient has this systemic inflammatory response, all the things that happen after that make that inflammation worse, and it just keeps getting worse and worse and worse and worse. This is why we have to catch it early, or the risk of mortality is going to be very high. Okay, so how do we identify these patients? Okay, there is something that we call SIRS criteria. You may have seen it in your hospitals. Those of you that work in hospitals or have spent any time in hospitals, you may have heard talk of the SIRS criteria. So this is a systemic inflammatory response syndrome criteria. This was created to help us identify patients who are at risk for sepsis, okay, or that may be potentially developing sepsis. It says at the top here, suspected or identified infection with at least 2 of the following. Okay, so let's talk about these a little bit individually. So abnormal white blood cell count, greater than 12,000 or less than 4,000. What's a normal white blood cell count? 5 to 10,000 is normal white blood cell count, okay? So greater than 12,000 or less than 4,000. Normal white blood cell count with greater than 10% bands. Who remembers what bands are? Anybody? So bands are basically baby white blood cells, okay? Immature white blood cells. Those are bands, okay? So our white blood cell count being greater than 12,000 makes sense, right? We have this big systemic infection going on. White blood cells are being released everywhere to try to fight the infection. That makes sense, right? Why would our patient possibly have a low white blood cell count?
Bless you.
Why would they have a low white blood cell count? So
Not fighting the infection?
it is fighting the infection. What happens is sometimes these infections are so bad and the immune response tries to jump in there so quickly that we start using up our white blood cells, okay? So depending on where you catch this sepsis, depending on where in the cascade you catch it, your patient may have been fighting this infection so hard that they've started to use up all their white blood cells and their white blood cell count actually goes down below normal, okay? We're gonna get to that. So that's where the bands come in also. So I said that bands are immature white blood cells, okay, or baby white blood cells. So when you have this big systemic infection and your body's trying really hard to fight it off and sending all the white blood cells it has out to fight this infection, the body starts to recognize that, hey, it's using up all these white blood cells, we better make some more white blood cells, okay? So the body will kick in and start pumping out new baby white blood cells, so that immature white blood cell count will start to go up also, okay? In response to this big infection. Heart rate greater than 90, well that makes sense, right? We said that in patients with sepsis, they're gonna have some hypotension due to vasodilation. The heart's gonna make up for that, but increasing its pumping rate, right? It's gonna try to pump faster to get that blood pressure back up, okay? Respiratory rate greater than 20. We said that's because as a result of that vasodilation and hypotension, the tissues become hypoxic. The tissues aren't getting enough blood flow or enough perfusion. Oxygen saturation of those tissues goes down. The body compensates by increasing its respiratory rate, okay? Now temperature, it says greater than 101 or less than 96.8, that's Fahrenheit. Here's the thing about temperature. Temperature is not a good indicator of sepsis. Temperature can be all over the place. It can be low, it can be high, it can be normal. So it's not a very good indicator of sepsis, okay? We're also going to be looking at urine output and changes in the patient's mental status. But temperature is not the best indicator. The other ones are better ones to go by. Now, I do want to point something out about this year's criteria, which is going to make more sense at the end of class. If you think about all the patients that you see in the hospital, you're going to see a lot this semester on the med-surg floors. Think about this criteria, and it says a patient with a suspected or identified infection with two of the following. How many patients do you think meet this search criteria? A whole lot of patients, right? Do you think all of those patients that meet this criteria have sepsis? Not at all. Okay, we're going to talk about why that's important at the end, towards the end of class. But for now, this is what we have to identify our patients who are at risk for sepsis. Okay. So what are we going to do about these patients? Okay. What are we going to do for patients that we think have sepsis or that we know have sepsis? Okay. Now, these are divided up into two different treatment bundles. One, it's in your book. There's two little charts in your book. The first treatment bundle says within 3 hours of identifying the patient has sepsis. The other treatment bundle is within 6 hours of identifying that the patient has sepsis. Okay, so these are the things that we should be doing. First of all, we need to find out where the infection is, right? So we're going to obtain blood cultures to see what we're dealing with, okay? What kind of infection it is. Obtain a lactate level, which we'll talk about in a minute. We've got to give some antibiotics, okay? And we may need to give some fluids for that low blood pressure, okay? So let's talk about these a little bit individually. So let's see what we know about obtaining blood cultures. So if you call the provider and say, hey, Miss Smith in room 4 had surgery yesterday and I think that she's developing sepsis. She meets SIRS criteria. That provider is going to say to you, most likely, okay, let's go ahead and get blood cultures, let's get a lactate level, go ahead and give the patient some antibiotics, and we'll give them some fluids, okay? That's probably going to be your order set that you get from that provider. So let's talk about these blood cultures. How many sets of blood cultures are we going to do? At least 2, okay? Most of the time your order that you're going to get from the provider is going to say, do blood cultures times 2, okay? So what does that times 2 mean? Well, when you do blood cultures, they want you to do it from 2 different sites, okay? Many times if the patient has a central line, they're going to want you to do a set of cultures from that central line to see if possibly there's an infection in that central line, okay? They're also going to ask you probably to do a peripheral blood culture, which means you need to stick them in the arm, okay? To see if the infection's in the bloodstream, okay? Now, usually you will do those cultures 5 minutes apart at least. So you don't just stick them in this arm and immediately stick them in this arm, or stick them in this, or draw blood from the central line and then immediately draw it from the arm. They like you to do them 5 minutes apart, okay? And that's to ensure that we have really good samples, okay, and that nothing is cross-contaminated or anything like that. So at least 5 minutes apart, okay? Now, what do you think that you would do first? Would you do the blood cultures or give antibiotics first? Why would you do the cultures first?
You don't want the antibiotic to go ahead and start treating it for you.
Right, you don't want the antibiotic to skew your results of your blood culture, right? These are going to be IV antibiotics. This is not going to be a pill that they swallow and takes a while to work. This is going to be IV antibiotics that's going to go directly in the bloodstream and start fighting that infection. So you don't want to start their antibiotics and then do blood cultures because it can skew your blood culture result, okay? So you need to do the blood cultures first. That's going to be your priority. You want to get that sent to the lab. Now, antibiotics, if you have somebody that's on sepsis protocol, it's advised that you give their antibiotics within the first hour of suspecting they have sepsis. So if you call that provider and say, I think my patient has sepsis, and they say, do blood cultures and antibiotics, you've got 1 hour to get those blood cultures done and start those antibiotics, okay? Because you need to get it treated as quickly as possible. Now it says here, administer broad spectrum antibiotics. Why are we gonna give broad spectrum antibiotics? Because we don't know what the infection is, right? We don't know where it is yet, and we don't know what the bug is. We don't know what the bacteria is yet. So we're gonna give broad spectrum antibiotics that cover a range of things first, right? Now, what type of bacteria did I say was the #1 cause of sepsis? Gram-negative. So what type of antibiotic do we wanna give? Something that covers a gram-negative bacteria, right? It would behoove us to think that it's most likely a gram-negative bacteria. That's the leading cause of sepsis. So give an antibiotic that covers gram-negative bacteria so that we can get this treated as quickly as possible, okay? Now I'll put some examples up here. Vancomycin and Zosyn is a very popular combination of antibiotics that you're gonna get when you call the provider and think your patient has sepsis. They'll probably tell you to go ahead and start vancomycin and Zosyn, okay? Now let's talk about those for just a minute. So you're gonna get vancomycin and Zosyn, and just to give you an idea, vancomycin comes in a big bag. It's usually, I think, 200 milliliters or 250 milliliters bag, somewhere around there. It's a bigger bag, okay? Vancomycin you have to give over a longer period of time. So usually you give it like over an hour and a half, okay? Zosyn comes in a little tiny 50 ml bag, and you can give it over 30 minutes, okay? Now, let's suppose that your patient needs both of these antibiotics, okay? And they have a central line and a peripheral line. How are you gonna give these antibiotics? You're gonna give them possibly in 2 separate lines. You could do that. Are you gonna give them at the same time? Can you give them at the same time?
Sure.
What if your patient, okay, so we'll give them at the same time. We'll put the vancomycin in the central line, and we'll put the Zosyn in the peripheral line. Now your patient has a reaction to antibiotic. Which one do they have a reaction to? Do you know? There's no way to know, right? So if they turn red and swell up and stop breathing because you gave them these antibiotics, you have no idea which one it was, right? So you should not give them at the same time, okay? Especially if the patient's never had these before, or you're not sure if they've ever had a reaction to one of these drugs, you should not give them at the same time, okay? So if we determine we're gonna give them separately, so we know which one, if they have a reaction to it, which one it is, which one do you think we should give first? Why?
Sure.
Because it's a smaller amount and you can get it in faster, right? We said we have a 1 hour window to get them at least started. But if you have a patient that's septic, you want to get them treated as quickly as possible. So you got to think about how fast can I get these antibiotics in this patient, okay? So they would recommend that you give the one with a smaller volume first. Give Zosyn, you can give it in 30 minutes, okay? And then start your vancomycin, okay? Because that one takes a little bit longer to infuse. Now, after a few days go by, so in case you didn't know, blood cultures usually take a couple of days to come back with a final result, okay? It can take like 48 hours to get the final result of your blood cultures. So for the first couple of days, they'll get these broad spectrum antibiotics. When the blood cultures come back and we know exactly what bug we're dealing with, then we'll switch them to the narrow spectrum antibiotic that treats that particular bacteria, okay? Now let's talk about lactate for a second. It says up there that it's the hallmark of sepsis. What is lactate or lactic acid? Does anybody remember? It goes along with that, right? So we know you probably think of lactate or lactic acid in reference to exercise, right? If you go and do a really strenuous exercise or you go run 10 miles, your body may start to produce lactic acid, right? But what is lactic acid really? Why does our body produce it?
Lack of oxygen.
Lack of oxygen is exactly right. So lactic acid is produced by the body as a result of anaerobic metabolism. Remember, in your body you have aerobic metabolism, which means with the use of oxygen, and anaerobic metabolism without the use of oxygen, right? So Lactate is, the definition of lactate is the cellular marker for hypoxia, okay? So when your cells are hypoxic, they start to produce lactate or lactic acid. So that's why in our patients that are septic, remember we have that vasodilation, we have decreased perfusion to the tissues, decreased oxygen to the tissues. Tissues become hypoxic, they start going through anaerobic metabolism and produce lactic acid, okay? So lactic acid or lactate levels is one way that we identify sepsis. And we say that a patient with a lactate greater than 4 could possibly be septic. Now lactate can be used for other things, not just sepsis, okay? But lactate greater than 4 gives us an indication that there's sepsis going on. And the higher the lactate level, the worse it is, okay? Now, this says administer a fluid challenge for hypotension or a lactate greater than 4. So administering a fluid challenge makes sense for hypotension, right? I said you have this massive vasodilation, blood pressure goes down. One of the ways that you fix a blood pressure is to fill up the tank with fluid, right? If you put more fluid in the body, higher the blood pressure is going to be. Just like when you're dehydrated. If you're dehydrated, blood pressure goes down, you feel lightheaded, you feel dizzy, you drink more fluids, put more fluids in the body, blood pressure goes up. Okay, so that makes sense. So why would we give fluid for a high lactate then? Same reason, right? So it's not necessarily to, as far as, still gonna treat the blood pressure, but it's really the same reason. So remember we said vasodilation, decreased blood pressure, decreased perfusion to the tissues, decreased oxygen, right? Increased lactate. So if we give more fluid, okay, we're filling up that tank with volume, we increase perfusion to the tissues, increase oxygenation to the tissues, our lactate will start to come down. Okay, does that make sense? This is the formula that they use, by the way. This is the recommended amount of fluid that we give a patient who is septic with hypotension or a high lactate. It's 30 mLs per kilogram, okay? All right, this next part, I don't want you to focus too much on. This is an introductory med-surg course. This next part is really ICU level of care, but I want you to know what happens as this patient progresses, as they get worse with sepsis and start to move into severe sepsis and septic shock. I want you to be familiar with what kinds of things can happen to your patient or what we're gonna do for the patient. So if you give that fluid bolus that we talked about on the previous slide and your patient still continues to be hypotensive, that's when they will introduce vasopressors, okay? Things like Levophed, I think I have some down here, phenylephrine, Levophed, dopamine, those kinds of things. They will start to give vasopressors to try to increase the blood pressure, okay? Cause some vasoconstriction of those blood vessels. Our goal with the vasopressors is to maintain the mean arterial pressure greater than 65, okay? Why do we want their mean arterial pressure greater than 65? Does anybody know that one? So mean arterial pressure tells us if the organs are being perfused, okay? Especially renal perfusion is what we're really worried about, and brain perfusion, okay? If your patient has a mean arterial pressure of about 60 or 65, we can ensure that the kidneys are being perfused. If your mean arterial pressure is less than 60, probably the kidneys aren't getting such good perfusion, okay? Now you want your kidneys to get good perfusion because you don't want your patient to end up in renal failure, okay? And many times with these vasopressors in the ICU, when they give you your parameters for titrating that drip, they may not say titrate your Levophed to keep systolic blood pressure greater than 100. They may say titrate your Levophed to keep your MAP greater than 60 or greater than 65 because they're really worried about renal perfusion, okay? Also in the ICU, if they're on vasopressors and they're still hypotensive, they may introduce hemodynamic monitoring, which you don't need to worry about for this class. I'm just telling you what happens, okay? So we may be measuring, they may have to have a central line that measures central venous pressure and central venous O2 sat. We're gonna continue to keep measuring that lactic acid level, right? Because we want to know if those tissues are still hypoxic, are they becoming more hypoxic, or are they getting better, okay? And we can tell that by the lactic acid level. This is just some examples of vasoconstrictors or inotropic agents that we may use. Again, don't be worried about this. I just want you to start in your brain hearing these terms, so when you hear it in a clinical setting, you'll know what they're talking about, okay? So vasoconstrictors, dopamine, norepinephrine, phenylephrine, like we talked about, inotropic agents. Now, what inotropic agents do is they increase myocardial contractility. So they cause the heart muscle to squeeze more effectively. They make the pump of the heart more effective and increase cardiac output. So you may see dobutamine used or Primacor used, okay? But I want you guys to be focused on that 3-hour bundle. Other interventions, of course, are going to be providing oxygen therapy if your patient needs it, okay, and continuously monitoring their urine output. Okay, here's a few other things to think about with these septic patients that can happen. One of them is adrenal insufficiency, okay? Now, where's our adrenal glands? On top of our kidneys, right? There are these little tent-shaped glands that sit on top of the kidneys. Now, the adrenal glands are part of the endocrine system, and we're going to talk a lot about this when we get to endocrine, but remember the endocrine system is controlled by those negative feedback loops, right? You probably learned about this in physiology. So you've got your hypothalamus in your brain, right, that sends signals to the pituitary gland. Pituitary gland sends signals to all your endocrine glands, okay, including the adrenal gland. Well, whenever the body is septic and you have that decreased perfusion to the brain, you also get decreased perfusion to the hypothalamus and to the pituitary gland, which means that whole feedback loop can be affected. So the adrenal gland in particular is affected the most, and it doesn't get good signals from the brain, okay? The reason that's important though is remember that our adrenal gland secretes cortisol. Cortisol is a stress hormone, right? That helps us when our body is under stress. Releases cortisol, and it helps us deal with whatever stress our body is under, right? So a septic patient is definitely under stress, right? That's a body under stress, and it needs that adrenal gland to be functioning properly and releasing proper amounts of cortisol to help fight that infection, okay? So if your adrenal gland's not working correctly, called adrenal insufficiency, the body won't be getting enough cortisol. So a lot of times these patients will be given hydrocortisone IV, which is a synthetic type of cortisol to help with that process, okay? Now, blood glucose levels. You've got a body that's under stress. What happens to our blood glucose level when we are under stress? It goes up, right? For everybody, even in non-diabetic people, for everybody in this room, if you're under extreme stress, your glucose levels will go up, okay? Now, why would it be a bad thing for your glucose levels to be high if you're septic?
It'll feed the bacteria.
Feeds the bacteria, right? Bacteria loves sugar. The higher the sugar in the bloodstream, the better the bacteria survives, okay? So with septic patients, we need to keep a really good track of their blood glucose levels, and we need to make sure that their blood glucose is being controlled, okay? A lot of times, especially once these patients progress to severe sepsis and are in an ICU setting, they will be on an insulin drip. Even if they're not diabetic, they will be on an insulin drip to keep really tight control on their blood glucose levels, okay? Now the other thing, anticoagulation therapy. This is a little bit tricky. So remember I said when you have this big systemic inflammatory response and you have vasodilation, you have increased capillary permeability, you have leaking of blood in those capillaries, so you have blood pooling, right? You have blood pooling out in the capillaries. And then all these microthrombi, all these little tiny blood clots go out to the periphery to try to stop that bleeding, okay? So this is a little bit of a double-edged sword here. We may use anticoagulants such as heparin for all those microthrombi. Because remember what happened to the girl in the video. She had all those microthrombi that went out into her periphery to try to stop that blood pooling that was happening, but it ended up causing ischemia of her extremities, right? She got necrotic hands and necrotic feet and had to have amputations as a result. So sometimes we may use heparin to help with that problem, okay? To help dissolve some of those clots. But there's another problem with that. You still have all that vasodilation and you still have all those capillaries that are leaking and that blood pooling, and now you've added an anticoagulant on top of that, right? So you have to be very careful with heparin in these patients, because yeah, you might treat the microthrombi, but you can cause the patient to hemorrhage too, okay? They can have really serious bleeding issues. Administration of blood products. Now there's lots of reasons why we might administer blood products in a septic patient. What do you think the reasons might be?
Blood pressure.
Blood pressure, right? It's gonna fill up their volume, right? It's gonna add volume to the system, so it's gonna help with blood pressure. What are some other things that are in blood products that may be beneficial to these patients? Hmm? Red blood cells will increase oxygenation to the tissues, right? Especially if their body's under a high oxygen demand. If we introduce some extra red blood cells, that's going to get more oxygen to their tissues, right? Because within the red blood cells you have hemoglobin. Hemoglobin carries oxygen molecules, so the more red blood cells you have, the more oxygen to the tissues. So it's going to help with that. Now, think about with the formation of all those little microthrombi everywhere. She had mentioned DIC a while ago. So another thing that happens is your body develops all these little tiny blood clots, sends all these blood clots out to the periphery to try to stop that blood pooling that's happening in the capillaries. But they produce so many microthrombi that your body starts to use up its clotting factors, okay? So your patient's platelets may start to go down because it's using up all its platelets trying to control all this blood pooling that's going on, okay? So one of the things that's in blood products that can help is platelets, right? We can give platelets to patients to help replenish the loss of platelets when they're forming all those microthrombi, okay? Now, going back to DIC, does everybody know what DIC is? Do y'all remember hearing that? Disseminated intravascular clotting, okay, or disseminated intravascular coagulation. So what happens in DIC, and this is exactly what happens in septic patients. They have all this blood pooling, body responds, so the body sends all these microthrombi out to the body to try to stop the bleeding that's happening in the capillaries. Because it's forming so many clots at one time, it starts to use up all the clotting factors, okay? So then the patient starts having bleeding problems, okay? So how you'll recognize this a lot of times in septic patients is around their IV sites or around their central lines. They'll start to have oozing of blood. Around their Foley catheters, they'll start to ooze blood. You may even see it in their mucous membranes, that sort of thing. In their nasal passages, they'll start to have a bloody nose, and it's because they're using up all their clotting factors and those capillaries are still leaking, and so they have oozing of blood in different places, okay? Okay, so who do we need to monitor for sepsis? Well, really the answer to that question is everyone, okay? Everyone can be at risk for sepsis at one time or another, but to point out some people here in particular. In the emergency department, the same criteria is used, okay? So the same SIRS criteria is used, but we need to be really cognizant of identifying these patients early. So if we can identify them in the ER and get them started on antibiotics quickly, their risk of survival is much higher. Of course, our patients that are on our units and floors, okay, this includes everybody, right? Make sure we're doing thorough assessments on our patient and monitoring those at risk. So, who is at risk for sepsis? Who are our highest risk populations?
Elderly.
Very old. Very young. Who else?
Immunodeficient.
Immunocompromised patients for sure. Who else?
People with abdominal surgeries?
They're at higher risk because it's in the abdomen, right? Any patient who's had an invasive procedure. Any patient from as simple as getting stuck to get blood drawn or having an IV started, all the way up to major surgery. Any person that has had an invasive procedure or a incision made through their skin is at risk for sepsis, okay? Or an increased risk for sepsis. Who else? So we said very young, very old, immunocompromised, invasive procedures. What are some other comorbid conditions or other disease processes that would increase a patient's risk for sepsis?
Pneumonia.
Diabetics for sure, right? Especially if they have uncontrolled diabetes with that high glucose in their blood, right? Plus, diabetic patients don't heal as fast, right? Due to the damage to their tissues, they don't recover as quickly from things. Who else? Liver patients, okay, especially patients with hepatitis, patients with HIV, AIDS, higher susceptibility to sepsis. What about as far as nutrition goes? Who's going to be at higher risk for sepsis? Somebody who's malnourished, right? Our diet helps us fight infection, right? The healthier food that you eat, the better diet that you have, the better that you are at fighting infection. So if somebody's malnourished, they're going to be at higher risk. Does anybody know a certain population of patients that are prone to be malnourished? Alcoholics, exactly right. So that a lot of people don't realize that, but alcoholics tend to drink their calories and they don't have the best diets. They don't tend to eat enough food or the right types of food. They, mainly drink their calories, and so they tend to be very malnourished. So they are at higher risk for sepsis as well. And of course, patients at risk are recently discharged. So we said before that it's the highest readmission rate is for sepsis. So discharge teaching is very important. This is one of my little soapboxes that I'll get on. So you will think that when you first get out of school, you're going to be this super awesome nurse and you're always going to be that way and you're never going to stray from that, okay? But I promise you, the longer that you are a nurse and the busier that you get and the more overwhelmed that you get, things will start to lax a little bit in your nursing care. One of the places that I see nursing care lax is in discharge teaching. You get really busy, you've got 5 patients, they're all being discharged, your supervisor wants them all out within the next hour and you better do it because we got patients coming in, right? And this is something that you may lapse on. Please, please, please don't be the nurse that prints out a handout off the computer, hands it to the patient, says sign here and sends them on their way, okay? I guarantee you those patients won't do as well and they will end up back in the hospital. You really need to spend some time with discharge teaching. We're sending these patients home, like I said, quicker and sicker than ever before. So we're expecting that patients can now go home and take care of themselves and do the things that we used to do in the hospital, they have to now do at home, okay? So make sure you sit down with them and really do some really good teaching with them before they go home. So if you have a patient, say, that's had surgery and they're going to be discharged home and you want to prevent them from getting sepsis, what do you need to teach them before they go home?
To prevent from sepsis?
Yeah, to prevent them from developing sepsis, what do you need to teach them?
Well, I guess there's adequate wound care and hand washing.
Right, so all the things that we talk about to prevent infection, right? So hand washing is big. And don't assume, and this is with any teaching you ever do with a patient, don't assume that the public knows things. Especially us as nurses, and the more that we learn and the more educated we become, we think that everybody else knows the same stuff as us. They don't. The public does not know basic things that you think that they would know. So yes, teach them that they have to wash their hands after they go to the bathroom, okay? Or wash their hands before they eat, okay? So hand washing is very important. Wound care is very important, making sure they know how to care for any wound that they have. If they need home health involved, make sure that you get it involved, okay? Or if a caregiver or family member is going to be providing that wound care, make sure that they know how to do it properly, okay? What else can we teach them to prevent infection or prevent sepsis? How are they going to know if they have an infection? Not all patients know the signs and symptoms of infection, right? And you will see that when you're a nurse, you just assume people know when they're infected, but they may not know, right? So you got to teach them those signs and symptoms. Teaching them about redness and swelling and any discharge from their wound. If they have a fever, if they have chills, any of that sort of thing, okay? Make sure you're teaching them that stuff. What else could we teach them to make sure that they don't get an infection?
Properly taking their medicine if they're going home on antibiotics.
Exactly. If they're going home on antibiotics, they need to take all of that antibiotic until it's gone, right? Don't stop halfway through because you feel better. You have to take the entire thing until it's gone. Also make sure your patients are getting adequate nutrition. Remember we said malnourished patients are more likely to develop infection and develop sepsis. So make sure they have access to adequate nutrition and that they're getting that. Okay, as far as who we need in our team, I think this goes without saying, but it's interdisciplinary collaboration. So people that are going to help us take care of patients with sepsis or that are at risk for sepsis. Of course, respiratory therapists, right? Rapid response team, physicians or providers, dietitians, wound care, and pharmacists. Now, psychosocial needs of the patient. When you've determined that your patient has an infection and they may be heading towards sepsis, things can happen very quickly. Patients can go from having an infection to being in septic shock within 24 hours. I've seen it happen. So things can be happening very quickly. Patient can get very anxious and very nervous. Their family members can get very anxious and very nervous. They don't really know what's going on. There's lots of things happening. So make sure that you explain what's going on. Try to reassure them. Let them know you're doing everything that you can. One thing I used to always do as a bedside nurse, because especially working in an ICU setting, you don't always have time to sit down with the family and have these nice long discussions about what's going on. But one thing that I have found that's a good time saver, and this is just general knowledge for you guys, is when you're in a patient's room doing things to a patient, just talk out loud while you're doing it. Say everything that you're doing and why you're doing it. Then the patient knows what you're doing, and anybody that's in the room, a family member, knows what they're doing, and that provides so much reassurance for them. So if you're, drawing your blood cultures, just say what you're doing. I'm drawing blood cultures, this is why I'm doing it, so we can figure out what bacteria is in the bloodstream so that we can give the best antibiotic to treat this infection, okay? So anything that you are doing, just talk out loud through the steps of what you're doing, and that really provides a lot of reassurance to them, okay? Okay, I'm going to go through this next part really quickly because I want to have enough time to look at the case study. So now that I've told you all that stuff about SIRS criteria and sepsis and severe sepsis and septic shock and all that stuff, they have changed that entire thing, the powers that be. And the powers that be meaning the Society of Critical Care Medicine and I forgot the other organization that they work with. But in 2016, towards the end of 2016, they came out with brand new sepsis guidelines. Now, for the purposes of this class, you are not responsible for this. The reason I tell you this is because in your hospital settings, you may see this stuff, and I don't want you to be thinking, well, that's not what Ms. Arsenault said in class. This is totally different. But we are going by what the textbook still has printed in it, which is SIRS criteria and that whole cascade. So 2016 guidelines came out. They call them Sepsis 3. They have simplified all the definitions and taken out a few steps of this cascade, okay? So basically now all we have is sepsis and septic shocks. We don't have early sepsis. We don't have SIRS anymore. We don't have severe sepsis. And so, like I said, they took out SIRS criteria. They took out severe sepsis. They simplified it to just sepsis and septic shock. SIRS criteria is now called the Q-SOFA scale, okay? So basically what that is a patient with a known source of infection that has 2 out of 3 of this criteria. So they narrowed it down to only 3 criteria now. It's altered mental status, hypotension, or tachypnea. If they have 2 of 3 of those with a known source of infection, we say they're at risk for going down the sepsis road and we need to get them treated quickly. Okay, so they've kind of simplified this whole thing. And that's going back to where I said, look at this SIRS criteria. How many patients meet SIRS criteria in the hospital? Well, like everybody meets SIRS criteria. So one of the reasons they simplified it is because they found that we were over-treating sepsis. We were saying that way too many people had sepsis that really didn't because they met SIRS criteria. Okay, so they've tried to simplify it a little bit. And if you want to take a look at that Sepsis 3, the new Sepsis 3 guidelines that came out in 2016, I posted it on D2L for you guys. I know y'all have lots of extra time to be reading research articles and things. But just so you know, that's what's coming down the pipeline, and by the time you guys graduate, your hospitals will probably be doing that criteria, so I want you to be familiar with it. This is, again, the SOFA score, but this is a more complex SOFA score that providers will use to score patients for sepsis risk. And I also provided you guys with some resources there if you want to learn more about it. It's called the Surviving Sepsis Campaign. Let's see how much time we have left. Not much. I'm gonna switch gears here and we're gonna work on the case study because I want you guys to have time to see that.